I'm also delighted that Farah Diaz-Tello could join for a truly interdisciplinary panel. Interdisciplinary and interprofessional education and collaboration are a key element of CHP's mission. The themes concerning access to and justice around key reproductive health services and outcomes for women, families, and communities could not be more pressing and urgent. I'd like to thank our development team, Sophie Kaufman in ALPS, and Dr. Erica Golub for all of their work arranging this today. And I will now turn over the floor to Dr. Erica Golub, our moderator for today, to undertake introductions and get things started. Dr. Golub is an epidemiologist and full professor in the Health Sciences program, whose main focus of research is in the area of reproductive health, including access to, safety of, and ethics surrounding HIV prevention, methods, and contraception. Thank you.
Thank you so much, Dean Tai. Welcome everyone to the third CHP Grand Rounds this year. I'm really happy to welcome you to this terrific opportunity to hear from and engage with scholars and practitioners in reproductive justice. I'm happy to see a great mix of faculty, administration, undergraduate and graduate students, and staff in the audience. I'm going to say just one or two things for housekeeping in terms of the structure of the program. The session is being recorded and speakers gave their prior approval. The organization of today's presentation is going to be that first I will speak for a few minutes to introduce the themes and some framework questions that might be useful to guide our discussion. Then each presenter will speak for about 10 to 15 minutes, and we will then open for questions, comments, and discussion from the floor. We're hoping for a very interactive session today. Please put your questions or comments in the chat, and the chat will go to me, and I'll organize them and bring them into the discussion. You can also use your emojis to raise your hands to speak. The moderator co-host will control the mute and unmute button for participants to speak, and we also have a few polling questions to launch at some point, so get ready for those. Now on to our topic. As everyone is well aware, the Supreme Court is expected to submit a decision in June that may overturn Roe versus Wade, the 1973 Supreme Court decision that legalized abortion until fetal viability. It's called Dobbs versus Jackson Women's Health Organization. Low-income communities and Black, Latina, and Indigenous women will bear the heaviest brunt of these restrictions, as history has shown. These communities have already suffered the most from forced pregnancies or delayed abortions, given state-level abortion restrictions that started soon after Roe was passed, and other major factors such as the long-term ban on federal funding, for example, the Hyde Amendment. More than half of the states have prepared trigger laws to ban or severely restrict abortion to go into effect immediately once the Supreme Court decision is pronounced. In addition, many states have developed some exceptionally new punitive strategies, such as Texas, that deputizes private citizens to sue any persons, from healthcare providers to families to Uber drivers, that help a pregnant person have an abortion. And Oklahoma already announced a total ban on abortion at any time, with the sole exception of saving a woman's life. And Missouri, that's considering a bill that criminalizes persons going to another state to have an abortion. Some 19 states have laws against persons obtaining a medication abortion, whether that's pills through mail or telemedicine. And just 2.5 weeks ago, a 26-year-old Latina woman in Texas was imprisoned for murder, with bond set at $500,000 for allegedly having a self-induced abortion. In the New Yorker article by Kianga Yamada Taylor earlier this year, she describes the disproportionate toll on maternal deaths on Black and Puerto Rico women prior to Roe becoming law, saying, quote, one study found that 80% of deaths caused by septic abortions in New York City in the 1960s involved Black and Puerto Rican women. In Georgia, between 1965 and 67, the Black maternal death rate was 14 times that of white women. But restrictions to abortion care are not the only threat to the health and lives of low-income and Black and Latina and Indigenous people. We're all aware of the dramatic racial differences in maternal mortality associated with pregnancy and childbirth, and an increasing focus on structural racism embedded in the delivery of care to persons of color throughout the lifespan, as well as intergenerational stress from a long legacy of racism in the US. Black women are 3 to 4 times as likely to die from complications in pregnancy and childbirth as white women, a statistic that holds even when considering and holding constant their income and education. In 1994, Black feminists coined the term reproductive justice to characterize the entire context of making decisions on having children, including the right to create family, a right to abortion, a right to parent with dignity and without coercion, and a right to dissociate sex from reproduction. The framework centers voices of those most affected by unjust and inequitable policies and practices that prevent accessing these basic rights. I'd now like to introduce our speakers, 2 of the leading voices on reproductive justice who will share their insights, experiences, and data with us today. Dr. Monica Mclemore is Thelma Shobe Endowed Chair and Associate Professor at Family Healthcare Nursing Department and Research Scientist at Advancing New Standards in Reproductive Health, a member of the Bixby Center for Global Reproductive Health, the University of California in San Francisco. She retired from clinical practice as public health and staff nurse after 28 years of clinical nursing career. In 2019, her program of research is focused on an understanding of reproductive health and justice. She publishes widely, including research papers, op-eds, commentaries, and her research has been cited in the Huffington Post, Lavender Health, 5 amicus briefs to the Supreme Court of the United States, and 3 National Academies of Science, Engineering, and Medicine reports, as well as a data visualization project entitled How to Fix Maternal Mortality. The first step is to stop blaming women. It was published in 2019, the Future of Medicine edition of Scientific American. Her work has appeared widely, such as in publications of Dame Magazine, Politico, ProPublica, and NPR, and she is the recipient of numerous awards, currently serving as chair for the Sexual and Reproductive Health section of the American Public Health Association, APHA. She was inducted as a fellow of the American Academy of Nursing in 2019 and was named the Thelma Shobe Endowed Chair in 2021. Welcome. Farah Diaz-Tello, JD, is Senior Counsel and Legal Director for If, When, How, Lawyering for Reproductive Justice, where she helps develop and execute litigation strategy, contributes legal analysis and drafting expertise to assist state and grassroots partners in reaching their policy goals, and provides legal information and training to reproductive rights, health, and justice activists. Her work focuses on ensuring that people can access a full spectrum of pregnancy-related care within and without formal healthcare systems, with dignity and free from coercion and punishment. Farah continues and expands the work she began prior at SIA Legal Team, and prior to that at National Advocates for Pregnant Women, where she established and helmed programs in human rights and birth justice. Her publications for scholarly and popular press address criminalization of pregnancy outcomes, economic coercion in childbirth, obstetric violence, and reproductive issues in pop culture. And I'd like to add that Farah recently appeared in a good deal of press coverage on the woman Lizelle Herrera, arrested for alleged self-induced abortion in Texas. And I believe your organization, If, When, How, provided the bond money for her release, but I'll let you talk about that. Welcome, Farah. And the last thing I will do before turning it over to the speakers, thank you for your patience, is to put some framing questions into the chat that we will use as a guide. Let's see, to all participants that we have discussed ahead of time, and that might help us to come back to and review as we work our way through this session. I hope everyone can see them now. Great. Okay. So I'm going to start by asking Dr. Mclemore, Monica, to start with your opening remarks, and then we'll move to Farah. Thank you.
Thank you so much for having us, and just so grateful to be able to be here with all of you. Frankly, before I begin my formal comments, I want to thank the dean and the leadership for having me. I had forgotten about the CUNY session, which was entitled Achieving Health Equity, Reproductive Justice, Community Engagement, and Emancipatory Research Methods. So I'll probably hit on all of those topics in addition to my prepared comments. Before I begin, I believe that because reproductive justice is so much aligned with the human rights approach and principles, that it is necessary for me to provide you my affirmative consent. So not only have I affirmatively consented for this session to be recorded, I am also affirmatively consenting to screenshots and live tweeting and Instagram and social media and a whole variety of other pieces, because I am in the camp of individuals that believes if Nazis, bots, and trolls are the only people who are using tools to communicate directly with the public, then we shouldn't be confused about why misinformation is rampant. So you have my affirmative consent to use all of these things. To my co-speaker, Farah, and my co-author, and I'm not sure if we're going to talk about being co-authors as part of obstetric violence, but I'm sure that'll come up as part of the discussion. I am deeply humbled and very grateful to be here with you and your brilliance, and to be able to open up and talk a little bit about something that guides my work, my life, my research, and how I move in the world, and that is reproductive justice. So before I begin, I really appreciate the overview and the framing, Erica, for really setting us up very well, but I want to take us back further. And I want to ground us in the words of W.E.B. Du Bois. So for people who don't know him, renowned sociologist, first Black man to graduate with a PhD in sociology in the United States. And in 1906, he really challenged the bleak forecast and countered some arguments, some popular arguments at that time about inherent Black inferiority. And there was a report that came out called The Health Physique of the Negro American. And they were proceedings from an Atlanta conference that had occurred on Black health. And so I'm going to read exactly what he said, because these words still resonate today. The conference findings pointed to the impact of environmental and social conditions on Black morbidity and mortality rates. And in commenting on the higher Black rates, Du Bois noted that, quote, "The present differences in mortalities seem to be sufficiently explained by the conditions of life," end quote. And in my view, this was one of the first descriptions of social determinants of health. So as you can imagine, I want to sort of ground this not only in Du Bois's words, but I also want to ground this in why reproductive justice is so important, in contemporary terms. So usually when I have slides, and I decided to, as I get older and the more I have opportunity to talk with faculty, students, and staff, I am actually really being more intentional about generating a discussion and the exchange of ideas. And I find that slides are distracting sometimes. And so I want to talk to you a little bit about why I do this work. So normally if I had a slide set, this would be my positionality slide. So I for people who've heard me talk before, I was born a preemie in 1969. So all the work that I do is really, really personal. And my birthday is on New Year's Eve of 1969. So I was alive in the 60s for like 4 hours, right? However, my birthday should have been on Valentine's Day of 1970. And so when you go back to vital statistics and records, according to the 1969 report from the Centers for Disease Control and Prevention, or more specifically from the United States Department of Health, Education, and Welfare, which was what the Public Health Service's National Center for Health Statistics was called at that time. Since I was born in New Jersey, at that time, the total infant mortality rate total was 20 infants per 1,000 births. And it was 16 per 1,000 for white people. And since race wasn't classified for others, and it was not disaggregated, the others category rate was 35.3 deaths per 1,000. So basically double what the rates were for white people, all other races and ethnicity. So when we already know that prematurity is the lead indicator of infant death in the first year of life, I'm both lucky and grateful to be alive. So when Black women came together in 1994, because I think some history around reproductive justice is really important, particularly since the 12 Black women who coined the term, I'm lucky enough to work very closely in community with 4 of them. And one of them actually happens to be a postdoctoral scholar who is working very, very closely with me, Dr. Tony Bond. She and I will be boarding a plane to fly back to the San Francisco Bay Area for Alumni Weekend. So we can talk about reproductive justice this Friday to the alumni, faculty, students, and staff who will be attending. So I don't want us to think that reproductive justice, even though it was coined in 1994, is untouchable, unmalleable, and not growing over time, because the founding mothers are still around. And we are lucky to still be able to learn not only from their writings, but also from their wisdom. So it's in that context, the next set of comments that I'm going to make are going to be dedicated to them. You know, reproductive justice was coined in Chicago after this International Conference on Population and Development meeting went down in Cairo, Egypt. And the reason it came together is because people were really frustrated with this narrow frame or this binary when we talk about choice. And as one of the contemporary leaders of reproductive justice, Monica Ray Simpson, penned in an op-ed recently in the New York Times that really talked about reproductive justice is the ceiling, you know, and that row and choice and all those other, that was not the best we could get. That was the floor. So when you think about a human rights approach, when you think about really moving us away from false binaries like pro-life, or pro-choice, anti-abortion, pro-abortion, when you can get out of those polarized discussions and really ground yourself not only in how the public thinks about these issues, but also how science and data have shown that people react to these issues, you will find it's much more messy. It's a nuanced discussion where more people sit in the middle than actually on the ends. And I know Farah's going to show us maps and talk through some data around that. But the truth of the matter is when we're talking about abortion, when we're talking about family planning, contraception, menopause, infertility, cancer, birth, more people are in the middle than they are on the extreme. And so as long as that's true, then we keep hearing from the people on the extremes. And I think we need to have a new way to discuss reproductive health and reproductive rights. And that's why reproductive justice is so important. I want to supplement and add to what Erica graciously offered in her introduction. We have to talk about reproductive justice as a human rights-based framework that combines social justice with reproductive. And so that combination is really important and necessary in addition to, you know, the human rights approach, because that means that these are not legislatable, that they are not vote uponable, because human rights are afforded to sentient beings and citizens in our society. Now, yes, we need legal protections to be able to make sure that all citizens have access. Farah's going to talk about that. But a human rights approach is really, really necessary for us to move forward in the ways in which we think about reproductive health as we move forward in the future. Why does that matter? Well, I was lucky enough to sign on to the first ever maternal health amicus brief in the Jackson versus Dobbs, or Dobbs versus Mississippi. And why was that important? Because it was the first time an argument was made in a case to the Supreme Court that argued that pregnant, capable people and their individual rights, human rights, trump any state's rights, any state's interests in what occurs within their body. And that the bodily autonomy argument that historically we've always very much appreciated that we have bodily autonomy both in life and in death. I say this to learners all the time. Nobody can go dig up your remains without your consent, right? That this notion that we've had bodily autonomy over time is super important. And it is part of the sort of existential way in which we understand the human condition. So the idea that some state's interest can come along and really trump the human rights of a pregnant, capable person. To be part of that historic brief was a huge, I think, highlight for me in this juncture in my work and in my career, to be able to finally say that pregnant, capable people are the only arbiters of what happens to them, and that the state's interest stops where their interest begins, was huge. I want to close in my comments because I want to make sure we have time for discussion, because there's a million things I could talk about. The thing that bothers me most in this current moment is the doom and gloom narratives that go along with the fall of Roe, as if we haven't had many wins and accomplishments, many of which from the if, when, how team, but also when we think about the lawyering project and when we think about the Center for Reproductive Rights, we have had some wins. And so again, the polar extremes are always driving a discussion. Let me hip you to what some of the wins have been. A lot of people don't appreciate the impact and the necessariness of Whole Women's versus Hellerstedt, this idea of removing the undue burden standard. Why does that matter? Because that allowed us to shore up abortion law in states where it was sketchy. It allowed us to expand abortion access for advanced practice clinicians. People on this call probably don't know we had recent wins for advanced practice clinician provision of abortion in West Virginia, in New Jersey, in Hawaii, in Minnesota, because I was the expert witness in those cases. My scientific data were used in those cases to show the safety and the efficacy of advanced practice clinicians, meaning midwives, physician assistants, nurse practitioners, able to safely and competently provide abortion-related care, right? At some point, we could be pushing the boundaries and using reproductive justice to think about where are the other supports that we could be using to shore up care for pregnant, capable people and abortion access. Because there's two really low-hanging fruit pieces that we could do right now. The first one is expansion of midwifery. It is amazing to me that hospital-based midwives can catch living babies and shepherd living babies and living pregnant people through that process, but they are barred or inhibited from participating in induction terminations. That is very strange to me, right? We can expand midwifery practice and midwifery access right now if we really wanted to. The other place that I see a real opportunity for us to be able to expand care is to allow for the safe and early provision of miscarriage management and aspiration abortion via advanced practice clinicians, and to expand that universally as part of their skill set. So to me, this focusing on the shortcomings of Roe, the shortcomings of our past actions, reproductive justice frees us from all of that. And it provides us a very clear roadmap in terms of how we can move forward, in the future on the side of the people that we serve, to be able to competently and confidently be able to provide good community-based care. And I think it's really, really important that we continue to be in discussion interdisciplinarily and interprofessionally so that we can make reproductive justice our future North Star. So with that, thank you. I'm looking forward to hearing Farah's comments, and we can talk forever. So I'm gonna shut up now and let her speak.
Thank you so much, Monica. Great stuff. We're gonna get into it. And Farah, I'll turn it over to you, please. Thank you.
Yes, thank you so much. It's a pleasure to be here. Thank you to the leadership of Pace University for inviting me here. Enormous thank you to Dr. Mclemore for teeing this conversation up so perfectly. It is a pleasure to be in space with you at any point. So I wanted to start by acknowledging the enormous debt of gratitude that I owe to the founding foremothers of reproductive justice and to its current day standard bearers, including Dr. Mclemore. Because if it weren't for them, I wouldn't be able to do the work that I do. I've had the good fortune of being a lawyer in service of reproductive justice for my entire lawyering career. And to give you a little bit of a sense of what that means, or who, what if, when, how does, I'll just give you sort of a brief history of the organization, because I think it sort of neatly shows the evolution from reproductive rights to reproductive justice. So when our organization was founded, lo, these many years gone by, it started out as Law Students for Choice. And it was a sort of partner organization, twin star, you could say, with Medical Students for Choice. And over the years, it's been through several iterations, a name change to Law Students for Reproductive Justice, as it broadened to examine things from a reproductive justice perspective and not just a sort of abortion rights jurisprudence perspective, which we'll talk about in a little second. And then an evolution into if, when, how lawyering for reproductive justice as the organization began to work, not just with folks who were on law school campuses, but with lawyers throughout their lawyering careers, realizing that even though reproductive justice as a model is fundamentally a community organizing model, one that is predicated on sort of on these interdisciplinary conversations and on community conversations, that lawyers have a role to play in advancing reproductive justice. So as it stands currently, we use a variety of modalities. We organize lawyers throughout their lawyering career from the moment they set foot on campus to, heaven willing, the moment they are appointed to the US Supreme Court in a sort of counterpoint to conservative organizing in this way. We also provide legal information to people, and especially as it regards their potential rights and risks related to self-managed abortion, which we'll put a pin in for just a moment. We use the sort of typical lawyering tactics of litigation and policy advocacy, as well as run a legal defense fund, which you briefly referenced earlier, and we'll get a little bit more into. But all of this is in service of the idea that everybody deserves the rights and resources to determine if, when, and how to become pregnant, to create families and sustain families. In the sort of laborious consultation over what our name was going to be, the consultant said, "You keep saying if, when, and how. Why don't you just put it in the name?" And so we did, and it can be a little bit opaque, but I think that it sort of neatly encompasses the range of issues that we approach. So my particular focus within the work is on ensuring that people, regardless of their pregnancy outcome, can have a dignified experience and not be faced with coercion or punishment, whether that is from the state or whether that is from a private entity like a healthcare provider or health institutions. I would say that the through line of my career has been this question of what happens to people whose pregnancies, how they are, who they are, what happens falls outside of the mainstream norm of what the state says that a compliant and good pregnancy should look like. So whether that is people who are self-managing their abortions outside of the formal medical system, whether that is people who are making decisions about their births that an OBGYN wouldn't agree with, they opt for a home birth with a midwife or to give birth in a birthing center or any of these things. Do they experience, are they met with welcome and care, or are they met with hostility and suspicion? And of course, the sort of animating feature of all of this is the sort of societal questions, right? The isms that we see. First and foremost, like, are people experiencing racism? Are they having sexism enacted in the care that they receive when they seek that care? Are they being discriminated against on the basis of their poverty? And so on and so forth, their gender identity, their immigration status. And I think this is the really liberating feature of the reproductive justice framework is that, frankly, as somebody who is just a constitutional law nerd, and the sort of decisions of the Supreme Court really speak to me in this really, kind of dorky way, I see myself first and foremost as a human rights lawyer, because we need to be able to look beyond the structures that were created in a document, frankly, that was, a series of concessions with slaveholding states, that was not intended to encompass people, who look like me, who look like Dr. Mclemore, right? Like, we were considered not persons under the Constitution as it was originally written. And even in the Reconstruction Amendments, the 13th, 14th, and 15th Amendments that were passed after the Civil War to try to, that were tried, I think, in some small way to rectify the sins of the past. Even in those things, we would not have been considered full persons. So we want to look at this sort of more robust human rights model to determine what does it mean to be a rights-bearing individual in our society. Unfortunately, one of the places where that really breaks apart is in the context of pregnancy. So as Dr. Mclemore mentioned before, the idea that the state has some sort of interest in what happens inside of a person's body is something that is actually quite staggering if you think about it, right? Like, this is not something that we would understand or accept with respect to any other rights-bearing person until they become pregnant, because in Roe and that line of cases, the state has essentially identified an interest in the protection of potential fetal life, or in potential life. And the way that that has been carried out has had some deeply disturbing and harmful ramifications for pregnant people themselves. So, I think one thing that I would point back to was sort of unsung important holding of Roe is the idea that for the purposes of the 14th Amendment, a fetus is not considered a person. This is important because you run into these situations that I'll describe a little bit later on, as when you have sort of two sets of rights existing within one physical body, because then that means that the court is asked to sort of weigh the rights of one person against the rights of another person, and perhaps even require some sort of act or even harm to one person for the benefit of the other. And that's something that our courts recognize is harmful. There's language from all sorts of cases where people have demanded that somebody give up an organ or give up a bone marrow in order to save another person's life, and courts say no, we can't do that. We can't weigh one person against another. But when it's a pregnant individual, you see courts sort of more willing to traipse down that line of thinking. So a lot of the work that I've done throughout my career has been in providing defense to people who have been criminally prosecuted on the basis of the outcome of their pregnancy, whether that is somebody who experienced a miscarriage or stillbirth, gave birth to a baby who didn't survive, or even gave birth to a healthy baby, but did so in a way that somehow the state was offended by. And so that could include, somebody whose baby tested positive for a controlled substance at birth. And these prosecutions are all sort of underpinned by this idea that because the state has an interest in the protection of potential life, then the state has a right to essentially speak on behalf of the fetus, often in spite of the pregnant person, in order to effectuate that right. And so when that happens, not only can the state ban abortion, it can also tell people how they have to give birth. It can also punish people or civilly commit them, in fact, seize their bodies for not complying with healthcare advice because they are using alcohol or controlled substances. And this sort of parade of horribles that seems I think it would seem implausible to most sort of reasonable people on the street that this is something that could happen. And yet, unfortunately, this is sort of the day-to-day of my legal practice. You referenced earlier the arrest of Ms. Lizelle Herrera that took place in Texas a couple of weeks ago. And I wanted to unpack that a little bit for folks, because I thought that people might have questions about what happened, what's going on there. And so, a large portion of the work that we do is around ending the criminalization of people who self-manage their abortions. When I talk about self-managed abortion, what I mean is any means that a person might use to end a pregnancy. So that could be abortion with pills, very often the same pills that they might receive from a clinical provider. They're more, increasingly, those are available by mail in states that allow it. But also increasingly criminalized in states that don't. So we see this sort of divergence in approaches among the states. And in the vast majority of states, in fact, this is the part, I try to liberate everybody from the tyranny of the PowerPoint, but I do want to share some slides because I think that they neatly show the chasm between law and justice. So let me go ahead and share these with you. Okay, so in the vast majority of states, it is actually not a crime for an individual to end their own pregnancy. So a self-induced abortion, there are very few states that remain that have laws on the books that say that it's a crime for an individual to end their own pregnancy. And in fact, this is something you see in Roe and like historically, and even in the common law, the law that we inherited as a colony of Britain, an unlawful abortion was something that one person did to another person, not something that an individual did to their own body. So the states that you see here, Nevada, Oklahoma, and South Carolina, are the only remaining states that have laws on the books. One of the questions that was posed to us, or what are some of the victories? Those states that you see in green and the one that you see there in yellow, those are states where there have been successful campaigns to repeal laws or to challenge them in the courts to remove these antiquated laws that punish people for ending their own pregnancies. Unfortunately, there are many more states that have criminal abortion laws that again, criminalize an abortion that one person does to another. But because of the way they're written, prosecutors have seized upon this idea, essentially that a person is their own unlawful abortionist and prosecutes them that way. And then these are states with fetal assault or fetal harm laws that are, this is, sort of perverse, but they're generally passed in the name of protecting pregnant people from harm. So preventing attacks or assaults that would cause a pregnant person to lose their pregnancy. And then when these laws are passed, this is the justification that is given, but generally then they are turned around and used against a pregnant person as though they, essentially like committed a crime against the fetus that they were carrying. And the states that you see here, actually the majority of states, 38 states have such laws. The ones that you see highlighted are the ones that don't have explicit protections for the pregnant person. So, if you look at all these things, you would say, well, is this really a problem? Is the criminalization of people who end their own pregnancies really a problem? There are very few states, their laws are seldom used. And that's the sort of just the plainly legal perspective. But when we sort of broaden out to look at what's really going on in people's lives, these are the states in which there have actually been prosecutions and criminal investigations for people who have been accused of ending their own pregnancy. Texas was on the list before 2 weeks ago. But what happened in that case, in what has been publicly released in that case is that Ms. Herrera went to a local hospital, whatever it is that she told the healthcare providers at that hospital, they reported it to law enforcement as a quote unquote a self-induced abortion. And so she was charged. The indictment said that the charge was homicide, so murder by self-induced abortion. Now, I could scroll us back a couple. Texas is not one of the states that has a criminal statute criminalizing self-managed abortion. It's unborn victims of violence set of laws explicitly states that it is not a crime for an individual. Any act or omission that has an outcome on their pregnancy isn't a crime. This was, plainly an act of prosecutorial overreach. Somebody was misusing the law. And fortunately, we were able to get in there and provide legal arguments and support to her counsel to have her released. It was essentially immediately over the weekend after the activists from Terra Fund and South Texans for Reproductive Justice and the National Latina Institute for Reproductive Justice, Poderosas, who are based in South Texas, brought national attention and national spotlight on this. At that point, the DA had no choice other than to abandon this wrong-minded prosecution. But unfortunately, all of it started because of an interaction between an individual and a healthcare provider, right? Somebody reached out to healthcare providers for support and instead ended up jailed for homicide. And that is where I am most interested in having these interdisciplinary conversations. Another sort of aspect of our work is providing legal information to healthcare providers, to people who are directly interacting with people who may end their pregnancies, but just with pregnant people in general, to help them understand what their real responsibilities are in this area, and that those responsibilities weigh in favor of protecting patient confidentiality and helping to protect their patients from violence on the part of the state. So I want to close out with a positive, right? Like this is scary, disturbing stuff. But one of the positives is that there have been reforms in states, even very recently. Actually, I think it's been good to my heart this year that every time I show the slide, it turns out it's dead letter. So these are states that have passed anti-criminalization provisions. I think I would add Colorado recently passed reform as well. And these are states where, coalitions of reproductive rights, health and justice activists, together with medical communities, with other, with activists in these areas, have demanded reforms that say that states that have protections for reproductive rights, they have, reproductive rights protections in their civil rights codes or in their human rights codes, have to include within that a freedom from criminalization and freedom from punishment by the state for people based on their reproductive decision-making or on their experiences. So whereas a solely reproductive rights model sort of leaves us at the doorstep of an individual has a right to seek an abortion without undue burden by the state, a reproductive justice approach actually pushes us to look at what happens to people, what are their experiences like when they seek care, because in Roe, the state or the Supreme Court didn't say anything about whether or not it was valid to criminally punish people for having abortions, for ending their own pregnancies, for anything relating to their births. So when we sort of flip into the human rights model, we have open to us the opportunity to make demands of the state I like these are unlegislatable. These are like, these are human rights that deserve to be protected. People's rights to make decisions about pregnancy, about birthing, and about these fundamental aspects of what it means to be human without punishment by the state. So these are the states that have been at the vanguard of that, and we're hoping for more. We have bills running in California, Louisiana, and I think that is all for the, in New York for this session. So anyway, I would love to talk more about this, but I'm going to pause and stop the screen share. Okay.
Thank you so much. Wow. Okay, that's a lot. And there's so much to get into. And I sort of feel like I'm so bubbling over with questions. I wanted to invite everyone that's here with us to please put questions in the chat and or raise your hands, and we can just jump right in. I'll start with one of my million. So I think it's sort of really to both of you. I mean, Monica, you mentioned doom and gloom, and I do, and both of you actually, and I do need to say that with my students, and when we consider these issues, there is a lot of doom and gloom among the young persons in the class now, in my classes, just in terms of what awaits me, and so, and one of the questions in the chat is really, what have been some of the successes, and what, in what ways can we jump in and make things better, and what progress, is there. And so that is really an aim of, I think, this conversation is to sort of combat that doom and gloom. And I guess in thinking about this, I also wonder, sort of, as an adjunct to that question, in terms of like the legislation and just trying to sort of run fast enough to escape sometimes it seems like, okay, we're just running so fast enough with our new tools for self-induced abortion, or our new tools for covert, whatever it is, and our new pills, or our legislation. But it must be more than that you see, sort of running ahead of, sort of what's behind. So I don't know who wants to take a first stab at that question, or.
Oh, I'm going first on that one, because I think it's super important that we remember a couple of things, right? So number one, it should be very obvious now that the reproductive justice language is in the cultural lexicon, that it should be very clear for people to have a framework as to why voting rights are a reproductive justice issue. Because if we're looking at and for people who didn't tie this together before, let me connect the dots, right? The notion that we will achieve health equity is one that I think is achievable and attainable in our lifetime. But that said, if we don't have legislatures and elected representatives who actually understand these issues, then the interests of the people are not being represented. So I hope, number one, it activates younger people to start to think about whether or not they have any interest at all in running for office, because I know I talk to my students about that all the time. Because if the people who are elected to represent our interests are not going to do so, then they need to be removed. So that's number one. Number two, one of the other things that reproductive justice has allowed us to do is to open some conversations. I know I've been a contiguously licensed nurse since 1993. And for me, I have been trying to push a lot of people to think about bolder approaches to how do we ensure access to abortion, reproductive health rights and justice services, infertility, menopause, all of it. I mean, I was on abortion-related billboards to try and get fact-based information to the public, right? So for me, it's also open to discussion. For years, the American Hospital Association, the Institute for Healthcare Improvement, Joint Commission, nobody wanted to have a conversation with Dr. Mclemore or a whole lot of other people about what does hospital-based abortion services look like, or what are we going to do when federal role falls. All of a sudden, my phone is blowing up, right, to have this discussion. And I keep talking to all the organizations that have had a lot of focus and attention on maternal morbidity and mortality. So when you think about the Momnibus and Build Back Better and infrastructure bills where there are hundreds of millions of dollars to reduce maternal morbidity and mortality, I'm the person in a lot of those rooms constantly saying, okay, so what's the plan once the 800,000 pregnancies that normally would have ended in abortion in the United States, once those individuals are forced to birth, they're going to be coming into what we already consider to be either a broken maternal health system or trying to birth in a system where we talk about a Black maternal health crisis, right? We just had Black Maternal Health Awareness Week last week. So I keep asking people, what's the plan? And there are actually people who are trying to think about what that plan is and understanding what their role and responsibility is. Or when I go to the Rural Hospital Association and I talk to them about the recent closures of their rural obstetric units. And I'm like, okay, so where does all that expertise go when you close those units? Because I really hope that you're either working with home visiting so that we can have that triage expertise that gets lost in those OB units, or those nurses are going downstairs to work in the emergency department, because we're going to need that level of surveillance. So finally, people are willing to have the discussion around how what happens in abortion space has been nothing but a canary in the coal mine. And I think COVID has also elucidated some of that as well, that there are real gaps in our infrastructure for the people who are most vulnerable, and that there is some real work that we can be doing right now. That said, I also hope that younger people can also appreciate the fight that's necessary, not only for, organizing and unionization, but this idea that we don't even have paid family leave, or that we don't have basic minimum income for individuals. I mean, there are things that we can do that are more upstream, not to end abortion, but to give people those dignified supports that they need in order to make the decisions that they need to across the reproductive life course that will allow them to operationalize their human rights as citizens. That's the power of reproductive justice, that we can have different conversations that are more nuanced and difficult. And I keep coming back to very conservative, very religiously affiliated folks. And I'm saying, you will get what you want that you've worked for in the last 30 years, right? If you want to, or the last 50 years, you want to up enroll, you want to make abortion illegal in the United States, what's the plan? And they stare at you dumbfounded. And they ask me, well, Dr. Mclemore, what do you think? And I'm like, okay, now we can have a discussion about why reproductive justice is so important, why abortion is an essential component to that. And now we need to figure out, okay, so then if clinics are going to close and people are going to lose access to services, then how are we going to care for all of those pregnant people?
Thank you. Thank you. Farah, would you like to add some responses to that?
Is there even anything to add to that? No. So, I mean, one of the things that I keep coming back to as a lawyer is that, that, like Dr. Mclemore said, there has to be a fundamental change in how we are approaching these issues. From a legal and policy level, the electoral politics, voting rights, all of these things are critical, or else the work that me and my comrade lawyers are doing, all of that is just purely academic, rearranging the deck chairs on the Titanic of a sinking ship, because, often we're looking at what policy outcomes might be based on the legislature, and we're up against math, just sheer math, districts that have been gerrymandered out of existence, all of these things for people who care, who meaningfully care about people's reproductive health, their outcomes, and want to see a just and equitable society. That has to change, right? That's sort of the step one. The other thing that I want to point to, places where there is so much room for victories in the small moments, is the way that I like to think about it, is what are the things that people have within their levers of access and within their discretion and ability to make decisions. And so, I think about situations like Ms. Hedada's arrest, and about her, actually reaching out to healthcare providers and ending up reported to law enforcement. Well, that is not something that is required. I think a lot of people may be under the misbegotten impression that it is required in some way that healthcare providers participate in the criminalization or state punishment of their patients. And that is simply not the case. And I think that, one of the things that we need to think about as we're moving forward, I think you put it very well, what are we running from that's behind us? I want to think of us as maybe just moving off of that track a little bit and thinking about the possibility that safety in a lot of ways doesn't come from the state. It's not going to come from the state. And that in many cases, actually, people need safety from the state. And it is state power and authority, surveillance and control that are the things that are actually going to be harming the very individuals that people are seeking to care for. And so, I urge healthcare providers, future healthcare providers, to be complicit in the liberation of their patients, of the people that they care for, and really, take seriously the admonition to do no harm, and, in fact, to prevent harm. When we see that the actions that the state takes or the actions the state demands can be very harmful. And I think about this in particular when it comes to self-managed abortion. I think that we have been fooling ourselves for a long time if we thought that all abortion could be institutionalized, or that is a desirable outcome for everybody. There are many people for whom, a clinic space or even a health facility space is not one that's welcoming or safe for a variety of reasons. And so, we have to think differently about how we approach that, what narratives we surface as we're seeking to oppose these, bad laws that seek to restrict abortion rights. Are we demonizing and vilifying people who are self-managing their abortions and sort of casting them in an air of suspicion that leads to ultimately their criminalization, regardless of whether the state demands it or not? We end up in these situations like happened in Texas. So so I think that this is one of those places where people actually have a lot more agency, a lot more power to be of service than they may have ever recognized. We see, sort of the admonitions of the state as a wall, when the truth is that we all have access to levers in these small moments that can help promote human dignity.
Great. And so
one more point on that though, Erica.
Oh, yeah,
sure. You asked a very specific question about young people and early career folks and students, right? So number one, students don't understand the power that they have. And so it was in California that students organized to be able to make sure that medication abortion could be available on college campuses. That's why we have a statewide initiative to make sure that the CSUs and the UCs can have access to medication abortion in their student health center and not have to be referred out to a Planned Parenthood or an independent clinic. That was student organizing that changed the legislation in the state of California. So for me, part of it, vote, get together with your friends, make sure you're sharing fact-based information on social media. Oh, by the way, consider joining the health professions and think about running for office. How about that? Right? Because those are some very concrete things. The other thing you want to do is lift up the work of reproductive justice organizers in the South. If you have coins or if your parents do, send money to the National Network of Abortion Funds. You don't need to start a whole new organization. There is already mutual aid for abortion and very well-oiled infrastructure within the country that has existed to get people the practical support that they need, whether it's transportation, plane tickets, train tickets, childcare, money for gas, whatever it is. That already exists. That doesn't need to be created. All you need to do is amplify and endorse. So that's like 7 things right there they can do right now.
That's great. That's really great. Thank you. Thank you for adding that and for reminding us how important democracy is for this whole movement. We do have a couple questions coming in, and we have a couple raised hands. I'm going to talk about some of the questions here. We have some student questions. Dr. Mclemore talks about how the pregnant person should be the only one to make the choices regarding pregnancy and not the state. Can she elaborate on reproductive care for women and how she wants women to give birth a certain way? I'm assuming, I'm not exactly sure how to interpret that question. I'll just leave it at that. And then there is another question about anti-abortion politicians often make an argument that abortion access is abused by those who have had one or more abortions in their past. Have you found any significant research concerning this argument that may disprove it, especially in minority communities? That is another student question. And maybe we'll start there, and then we'll go to Dr. Salzer, who I think has been waiting patiently, raising his hand.
Well, first of all, any number of abortions and any sort of pitting folks against each other in terms of numbers of abortions or when they have them, in my opinion, is a stigma response. And I say that because the life circumstances and conditions of pregnant, capable people, again, they are the only arbiters that can decide that they want to live with the lifelong consequences of continuing a pregnancy or ending one. And the notion that we can be arrogant enough to think that we can opine about that, I think is really what we need to unpack. I also like to point out, we think about how, to Farah's point around other clinical conditions where this would be completely unacceptable. I always like to remind people, please talk to friends and family, get them the evidence-based information. My PhD is in oncology genomics. I'm a laboratory-based scientist. I say this to people all the time. And tumors are alive. We treat them very differently. We treat how we, clinically manage them, how we think of war on cancer, right? We think about it really, really differently in terms of other biological phenomena that invade us as human species. And so this notion that, the sentience or therefore or not of fetuses is the real fundamental crux issue that we need to talk about in those interests. Get into the birth piece still, because I think that's a really important question. I think I understand what the student is saying, and if I'm not, please clarify in the chat. But pregnant people are also the only people who are the arbiters of where, when, and how they birth, right? So for me, right, it's no different. If so-called high-risk people want to be able to have a home birth with a midwife, they should be allowed to have a home birth with a midwife. If that's so, and if there's a transfer of care that needs to happen or needs to occur, then it's our job as the health system to facilitate that, not to stigma, shame, judgment, and blame them because they never should have been in that setting in the first place, because that gets to building the settings of care that are necessary for us to be able to optimize good health outcomes. There's a National Academies of Science, Engineering, and Medicine brief about birth settings that came out in 2020, and my work was cited in that report, because we wanted to look at all the levels of evidence to figure out where we could assure the best birth outcomes. One of my big arguments around that report was this: no one has ever gone into wealthy communities to document the minimum set of criteria or things or supports that folks need in order to ensure healthy outcomes. And we've never made a collective decision as a society to ensure that everybody had access to those things. So any risk perception that we have around pregnancy, regardless of how it ends, is always an estimate, because we don't have a shared baseline about what are the essential components that are necessary to ensure those good outcomes, regardless of how pregnancies end. So to me, life is not without risk. You can walk out the front door and get hit by a car. So that we make pregnancy-related risk very different than other risks that people take on in life. And this should have been proven true in COVID as well, right? It's artificial. And that's where I say we need a more difficult and a more nuanced and a more curated space to be able to have some of these conversations, because we act like risk is equitably shared and we act like there's no way to reduce harm. And those two things are not true.
Some thoughts to add to that as well. So, one of the, a concept that I am sure it exists elsewhere, but I learned it from disability justice advocates, so I like to credit them for it, is this concept of the dignity of risk. Is that, as human beings, we decide what risks we want to take on. And, it is fundamental in our constitutional jurisprudence, in our common law rights, that we have the right to make these decisions about ourselves, even if they ultimately turn out to be the wrong decisions, even if they turn out to be harmful. You have a right to make these decisions, to refuse even life-saving medical care. And just to give an example, based in New York, of what it looks like for the state to tell people how they should give birth, a case that I've been working on for virtually my entire career because it has dragged on in litigation for so long, emerged out of Staten Island. Actually, a Brooklyn woman who had had 2 cesarean births and wanted to avoid having a third one for cultural and religious reasons, decided that she wanted to have a vaginal delivery after cesarean. And she took advantage of New York's Maternity Information Act, which requires that all hospitals publicize their rates of cesarean surgery, their VBAC rates, their rates of instrumental deliveries. Every hospital has to provide this information for the Department of Health website. She went on and found that the hospital with the lowest C-section rate in New York City was Staten Island University Hospital. So she arranged to deliver there. But unfortunately, on the day that she actually showed up to deliver, the healthcare provider she had been working with wasn't the one who was present. He wasn't the one in the practice who was present. And the one who was urged her from the moment she walked in, you've already had 2 surgeries, you should go ahead and have another, right? And ultimately, like her labor progressed very slowly. And at one point he told her, that's it, I'm not going to examine you anymore. In the record, she says that he said, my license is more important. If you want to rupture your uterus, you just go home, because there is a potential risk in a vaginal delivery after cesarean section of a uterine rupture, which can have some serious consequences. It is also a risk in an induced labor. It is also a risk in a first-time labor, right? Like the risk of uterine rupture is not unique to vaginal delivery after cesarean surgery. And she said no, she wanted more time to labor and to let the birth occur naturally. And so what the physician did was called in a maternal fetal medicine specialist to try to persuade her. And then they noted in her record, the patient has decisional capacity, right? So she is able to make her own health decisions. The fetus is more than 24 weeks, has no fatal anomalies. So kind of doing the sort of quasi-Roe like weighing of viability. We've decided to override her decision, and they subjected her to an unconsented cesarean surgery. As she was being wheeled down the hallway, she was saying, please don't do this. I don't want to be cut. And the surgery that they thought was going to be a sort of easy solution to her labor actually ended up being a fight for her life. She was in surgery for 5 hours. They bisected her bladder. And, unfortunately, the way that our law currently is, and sort of building the law around people's civil rights in pregnancy, all that she has available to her really is causes of action for malpractice. And the way that the law views it is like, apart from battery, which is like if somebody does a surgery or, a procedure without your consent, that they could do a technically perfect cesarean surgery that wouldn't be considered malpractice, even if the patient didn't, even if the patient was objecting to it at the time, which I think is absurd. And one of the arguments that she's raised throughout is that the healthcare that violates ethical standards can't be medical care that is within good sound medical practice, right? But this is sort of an area of law that's still in development. But one of the sort of most galling things that the hospital has said in its defense, apart from essentially, yes, we battered her, but we have the right to do so. A private party, this is not the state. They didn't seek a court order. They didn't institute any kind of a legal process. They put into place their own process. It was an undisclosed hospital policy that sort of laid out this decision-making process by which they would override the decisions of conscious and competent pregnant patients. So in their kind of like, in their hospital policy, there's no point where they say, and we will ask the person to sign a waiver saying that they are acting against medical advice and acknowledging the potential risks, right? That would be the thing that you want them to do. Instead, they say, we will override the decisions of competent pregnant patients. And for folks who practice in health facilities in New York, that every person who is admitted to a hospital in New York State receives the patient's Bill of Rights. It's the thing is like you have a right to make decisions. You have a right to understand your options and get a translator if you don't understand them, and the right to refuse medical procedures. But apparently, if you're pregnant, so says this hospital, those things are out the window because the state has an interest in the protection of potential life, and they, as a private party, were saying we are stepping into the shoes of the state and we're enforcing that interest by performing a surgery on an unconsenting patient. And good luck to her in trying to seek justice. It has been 8 years. I know because I started work on her case when my child was an infant, just like a babe in arms, and he's in the 3rd grade now. So this is, and this is what access to justice looks like for people who experience obstetric violence.
Wow. Okay. Right. Lots to unpack there. We have a hand up. I put a couple of people's questions also in the chat so people can consider it. Sophie, do you want to help with the hand? Or are you already unmuted? Great. Go ahead.
I am. Hi there. I'm Elijah Souls. I'm a physician assistant who specialized in obstetrics and gynecology for 30 years now. And I too, like Dr. Mclemore, could talk about this till all of the cows come home. So thank you both for a wonderful presentation. I have so many questions for you. There's no time for all of them. But I have 2 comments, if you will, one of which, and perhaps it's a very naive point, I know about the history of abortion in the United States going back to colonial times, and the change that occurred around the Civil War and Reconstruction, and then the waves of immigration to this country. And clearly the roots are in white supremacy and, of course, racism and misogyny. I don't understand why the religious right is perpetuating these policies and attempts to destroy what has existed for 50 years almost, which is only going to increase populations that they don't want because they're threatened about the possibility that they will get overtaken when there are fewer and fewer white people. So how does that work, if you will?
Well, if you do the math, right? I mean, so let's start off by saying that country was built on the backs of enslaved and displaced Native Indigenous individuals, right? Because the title of slavery and the status of slavery came down through the maternal lineage, right? So even after slavery ended, and we couldn't bring more slaves from Africa, pregnant people who are still here were still birthing slaves, right? Or enslaved persons. So let's just start there. The reason and so let's not make a distinction, at least in my mind, I don't, because I've recently been like a huge target of, death threats and alt-right and all this other ridiculousness because of the basic work that I do. The reason that the math works out on this is because if you conflate the Black maternal health crisis and the fact that Black women are 3 to 4 times more likely to die from pregnancy and childbirth complications, you decide all of a sudden that now you have to have forced birth, where individuals where pregnancies would have ended in abortion and probably life-saving abortion, then you actually could have a recipe for disaster around extinction of entire population of people, just based on this notion of the innate harms that are associated with pregnancy. See, that's the other thing, right? People don't appreciate the fact that becoming pregnant is not a risk-free decision.
Oh, no, you're 14 times more likely to die from pregnancy than you are
from abortion, right?
Yeah. So good point. Yeah, okay.
To think that their rationalization somehow is about the long game as it's been explained to me, and I spend a lot of time, and I'm an ex-evangelical, my parents still are evangelicals, and I went to evangelical high school. So for me, it is my understanding that this isn't about this life, it's about the next one. Mm-hmm. So if we can have genocides of people, if we can have folks dying now without any need to do anything about that in the real time right now, because you're saving up for the next life, or that someone's spiritual life is actually the only one you really care about, then it's real easy to think about how this conflation of ridiculousness is going to play out on the ground.
Fair enough.
I don't know that people are thinking about the now. I think they are thinking about the, vision of folks' afterlife, their next piece. Because if they were, then at least for authentic religiously affiliated people, wouldn't they want to follow in the steps of their so-called leaders, right? Feed the poor, take care of the widows, like do all that stuff that we think is good for humanity. Wouldn't we be doing that?
Mm-hmm. Agreed. Thank you.
They focus, they told us exactly who they are. Focus on the family, focus on the future. This isn't about the people in the now.
Yeah.
So that's how I think about it. And that's why I like reproductive justice, because reproductive justice is also about the people in the now. It is building the human rights framework, the coalition of the willing, people who are willing to stand and say that as sentient beings on this planet, these are the things that we need in order to be able to operationalize our reproductive life course, regardless of what that trajectory is. And that we want authentic ways to engage not only with the public, but with clinicians, with public health, with policymakers, to have a more troubled and nuanced discussion about this. I say this all the time. I tell this story not to stigmatize or to shame or to blame anybody, but to just show how complex this is. I am a childless by choice person. I have never been pregnant. I have been a nurse since 1993. I have no idea what pregnancy decision I would make. None. And I researched this.
Yeah.
Right?
Yep.
So this notion that there is some shared appreciation about the reproductive decision making and the process that people use, it is time and person and space specific, sensitive, so that there's some universal blanket way that we can all understand this, I think is false.
Thank you. I have cared for some of those patients who have been within a hair's breadth of death from septic abortion. And it's quite a place to be. My follow-up question, if you will, if I have time, given the complexities that if we didn't understand states' rights versus federal law before COVID, we certainly realize what a muddy water it is now. What do you see if Roe v. Wade is overturned? God help us. What do you think the FDA will do about mifepristone?
Oh, that's true. tricky. My colleagues at Advancing New Standards in Reproductive Health and the ANSWER program have been working on this for years. You
Yeah.
know, having, you know, in terms of RIMS and all of it, access. I'm gonna let Farah answer that one.
Well, let me just also qualify that, if you might, because mifepristone is increasingly of interest in treating endometriosis,
Yeah,
in
yeah.
treating fibroids, in treating incomplete abortions. But how do you do that if you can't get it?
Right. Farah.
Yeah. Oh gosh, I wish I had like a crystal ball. I don't, this is a tough question to answer, right? Because we have what the answer is under this administration, but if we're not playing the long game, we don't know what's going to happen with the next one. And this, you know, I would hate to see this become sort of the next political football that's back and forth. I think the easy answer to what's going to happen is this sort of like race to the bottom in approximately half of states, right? Like as it stands right now, 26 states have trigger bans. Abortion will become illegal in some way, form, or fashion if Roe is overturned. So encompassed within that is access to mifepristone. You know, the folks that Dr. Mclemore referenced at Answer, the Emma Project have been pushing for a long time to get the FDA where it is now. And that has been a laborious process over, you know, decades of work to get us to the place where we are now, which is not even where the WHO says that we should be in terms of offering, you know, self-directed, self-managed care as within the range of options that people have. So I think that my primary concern is not just what the FDA is going to do, but what is it that the states are going to do, the people who still continue to manage to access that care. Because at this point, you know, we live in a globalized society. People carry the, you know, computers with them in their pockets at all times that allow them to access medications in ways that would have been formerly incomprehensible. And I think that, you know, if we want to see what is likely to happen, we unfortunately have to look to states like Texas that are bellwethers because people there have always been able to easily move across borders. Medications flow easily across borders. And we've seen, you know, that criminalization transpires there, even in what is considered a favorable legal landscape. So I think, like, you know, the distinction, again, the chasm between the law and justice is one we need to keep an eye on and fortify protections to the extent possible.
I wanted just to take a time check here. Thank you. It's 4:43. We're only a couple of minutes away from our closing. Unfortunately, I feel like we just started to get into everything. There is one more question from a student. I think I'll you know, highlight in the chat there, which says, and maybe we can then take this out to the end if people want to stay, and I would love to continue, but she writes, as someone's going into the nursing field, I've learned that patient autonomy and advocacy are very important aspects in states where abortion is illegal. This creates an ethical dilemma in how nurses and physicians provide care to their patients. How can healthcare professionals in these states offer guidance to a patient who wishes to have an abortion? Well,
you know, I'm probably not the person that asked that because I'm a big fan of civil disobedience and direct action. I mean, my father is like a, you know, retired judge and was a constitutional lawyer who challenged a whole lot of unjust laws. So, you know, for me, and it's easy for me to say that because I don't live in one of those states, right? So for me, I always come back to, let's take a harm reduction approach. How can you get people to fact-based information? How can you ensure that they get the care that they need? And how can you partner with the individuals who will afford you the protections that you need to make sure that you are providing fact-based information and getting people to what they need? Farah?
Yeah. I mean, again, it comes back to the notion that safety doesn't necessarily come from the state. So regardless of what the state says, people are going to seek reproductive health care. People are going to find ways to, you know, make decisions about whether and when and how they give birth. And so, you know, I think, especially for folks who want to work in states with a more like hostile policy landscape towards people's reproductive freedom and autonomy, you know, the answers are apparent to the people who are there. And I have to say, you know, as a lawyer, it's possible that they're not telling me what their practices look like, what those small moments look like, because those things are happening outside of the scrutiny of the law. And so the information that a healthcare provider, you know, provides to somebody who turns to them for help, you know, that the privacy and the confidentiality of those moments is when it's virtually sacrosanct under the law. And so, you know, I may not have the answers, but I know that there are people who every day are providing care to people, you know, and unfortunately, this is the way that it was before the Roe decision. This is the way that it is today in states where Roe never permeated, was never quite enough. And it's what things are gonna look like in the future going forward. And a place to look, I think, is to other countries, right? I think that it is important for us to look beyond the US borders and see, what has happened in places that have been and have gotten beyond where it is that we're heading. So looking at the accompaniment models and harm reduction models and in Mexico, Argentina, Uruguay, right? All of these, their example.
Yeah.
Yes, and yes, exactly. So, folks, I think should look there, for solidarity and for direction forward.
Great, thank you. I wish we didn't have to close. We are at 4:45. There's so many more questions. Would you like to put, I see that Monica, you've put your contact information in the chat. Farah, would you like to also just put it in the chat for folks to continue?
I think she did already.
Oh, did you? Sorry, I'm sorry. Great. Okay. I wanted to really thank our two speakers. I have so many other questions myself that we didn't get into, and I think many of the other participants here, but we certainly had learned a lot and are going to leave with asking ourselves a lot of questions too, which is really the point as well of these presentations and these events, right? So thank you very much, and thank you to our participants, and thank you to our speakers, thank you to our staff, and everyone that made this possible. I appreciate the speakers' availability today. Thank you so much.
Thank you.
Thank you.